see my professor. Actually, without his great efforts, there would not be palliative care in Castlevania. Actually, he was the head of the department, and he did a great efforts and much support to start this palliative medicine. In other words, we were orphans. لكن هو تبنانا يعني. اوكي. هنبتدي بالانترودكشن باليتيف كير، وقبل ما ابتدي احنا بالتالي كله ما فيش مشكله لو اتكلمت عربي انسان انجلش، يعني ما فيش حد هنا انجلش نيتف خالص يعني. اوكي. طبعا انا كان نفسي الاتندنس يبقى احسن من كده بكتير، لكن كل ما بشوف المنظر ده بعرف ان انا على رايت تراك. اوكي. الباليتيف كير ما بدأش في أي مكان بسهولة خالص نهائي، حتى سلسلة سونجرز اللي كرموها في النهاية قعدت قد إيه؟ قعدت 30-40 سنة لغاية ما بدأ الناس يقولوا أنت بتعملي إيه؟ بدأوا يريكوجنايز وات شيز دوينج. الكلام ده كان في بريطانيا مش في مصر يعني. أوكي؟ بس المسج مني ليكم ما فيش حد يبقى فرستريتد. We are on the right track and we should be proud by what we are doing. We are relieving the suffering of patients. للأسف مفيش حد غيرنا بيساعد. Okay, so I will start by some words about palliative care. طبعا احنا يعني much of the time has been already، فأنا I will cut it short. ومعظمنا عارفين الكلام، بس ما زال برضه في some audience يعني ما يسمعوش كلام كده، ف I will try to make it short as much as I can. السلايد دي كم واحد هنا شافها؟ تقريبا هنا مثلا نص اللي هنا شافوها قبل كده يعني. تمام؟ فاللي شافها ما يردش عليا بعد اذنكم يعني. Please don't answer يعني. What's written on this? What's this first يعني?
Hepatocellular carcinoma.
Yes, HCC, advanced HCC. Plus ascites.
For supportive only.
For supportive treatment. Treatment only يعني. Okay, what's written in Arabic? Yes.
حالة سرطانية
ولا تعود. الكلام ده مكتوب على ايه؟ على ايه؟ what's written؟ يعني مكتوب على ورقة ايه؟ شكلها ايه؟ ده ظرف الأشعة. These patients had advanced hepatocellular carcinoma. He was suffering. وراح للي المفروض الانكولوجيست هي in a very reputable place actually يعني. كان reputable تحت السنة يعني. He wants help. And this is the response of the oncologist. طب يروح فين يعني؟ كوميدي سوسايد ينط من الدور الثالث يرمي نفسه تحت العربية يعمل ايه؟ Okay? This kind of patients they are suffering very much. Suffering physically, suffering psychologically, suffering socially, suffering spiritually, and need care. This is palliative care. This is simply what's palliative care. We look for these patients. Okay? طبعا أنا مش هقدر أغطي the whole presentation. Okay, so I will start يعني I will select some of the slides, important slides. طبعا احنا we are in an oncology conference. Okay, so it's important to note that almost 1 in 10 deaths in the whole world is due to cancer. 12% of the global deaths are due to cancer. In 2002, about 7 million died of cancer, and in 2020, expected to be 10 million died of cancer deaths, mainly in what's called developing countries in our region. And this is the WHO statement. In most of the world, the majority of cancer patients present with advanced disease. For them, the only realistic treatment option is pain relief and palliative care. And this is the list of symptoms suffered by patients at the end of life. You can see that almost 19 of these symptoms are present in more than 25% of patients. So it is not a pain issue only. Okay, some patients may suffer due to nausea, some patients may suffer due to cough, some patients may suffer due to dyspnea. So it is not only a pain management. So this is a kind of suffering, physical suffering. I will skip this, we'll talk about tomorrow. Okay, but the suffering is not only physical suffering. There is social suffering, spiritual suffering, and psychological suffering to give us the total suffering for the patients. Okay, and I'm sure most of you are either oncologists, whatever the specialty. I'm not sure about the all SNGs. I'm sure that at some stage of your life you encounter some patients for whom the suffering issue is not only physical. Okay, we make patients with social suffering, with spiritual suffering, with psychological suffering. It is not only physical. With this kind of suffering, the multi-dimensional suffering, we need a teamwork. Team physicians, nurses, physiotherapists, occupational therapists, psychologists, psychiatrists, dietitians, clinical pharmacists, spiritual advisors, counselors, social workers, to deliver what's called as total care. Okay? And the most important in this team is, don't say, the patient and the family. Okay, we are talking about patient-centered care. So it's very important to include in the team the patients and the family. So it is not only a medical specialty. Okay, palliative care is not only a medical specialty. We need a whole team. In addition to the physicians, we need nurses, we need chaplains, social workers, physiotherapists, occupational therapists, dietitians, pharmacists, etc. Okay, this is the staffing of palliative care unit in Edmonton, Canada in 1995. We come to the definition of palliative care. This is the WHO definition of palliative care. It's an approach. Okay, so palliative care is not a medical specialty. Okay, it's an approach of care that improves the quality of life. So the aim of palliative care is to improve the quality of life of patients and their families. Not only the patients, but the patients and families facing the problems associated with life-threatening illnesses. And in this definition, it was written in the cancer guidelines by the WHO, but they do not mention cancer, okay, in the definition. Because any patient with life-threatening illness who is dying with advanced incurable disease can benefit from palliative care, not only cancer patients. Through the prevention and relief of suffering. By means of early identification, impeccable assessment, treatment of pain and other problems, physical, psychosocial, and spiritual. This is what we have just said now. Okay, this is the definition of palliative care as defined by the WHO. Palliative medicine, we can say that palliative medicine is the medical part of palliative care. Okay, and that's what this definition is specified for palliative medicine. The definition by the Royal College of Physicians in the United Kingdom in 1987. When they wanted to recognize palliative medicine as a specialty, they made this definition. It is the study and management of patients with active, progressive, far advanced disease for whom the prognosis is limited and the focus of care is the quality of life. How did palliative care develop? First, of course, there are many stories on how did palliative care start actually. But this is one of the common stories that in the 19th century, the term hospice was first applied to a place dedicated to the care of dying. Then in Lyon, France, and this was followed by another one in Dublin, Ireland. Then in East London, England, in the early 20th century. Then came Cecil Saunders in the mid-50s and the early 60s. She established the first modern hospice. Okay, most of you, of course, are aware of her story. She started as a nurse, but due to medical problems, she stopped the nursing job and started to volunteer as a social worker. And through her work as a social worker and as a nurse, she noticed the difference between patients who die in hospitals and patients who die in hospices. Okay, in hospices they die comfortably. They used to give them the morphine around the clock to relieve their pain, while in hospitals it was not the same story. So she said, why not to medicalize what's going on in the hospitals? Okay, but at that stage she was still a nurse and a social worker. That's why she went to medical school, graduated as a doctor, and started St. Christopher Hospice in South London as the first modern hospice. After that, more advanced in palliative care, Dr. Barfour Mount first hospice units in Canada and called it palliative care. Actually, he was from a French-speaking area, and French-speaking areas, hospice means in Arabic tikaya, okay, a place for the poor to eat and to sleep. Okay, so the name itself was not suitable for the culture, and that's why we say palliative care. He coined the term palliative care. 1975, they started hospital-based palliative care units because many patients die in hospitals and they do not die in hospices, and so on. And this is the map how palliative care developed worldwide. This was in 2006. The countries in green are countries with integrated palliative care in the healthcare system or approaching integration. North America, most of North and West Europe, Australia, New Zealand, Japan, and some exceptions here, Uganda and Kenya, South Africa, etc. But still we are in the red zone, most of our countries here. And red means localized provision. So if someone in the whole country is saying I'm doing palliative care, they will say they have localized provision. But let me give you an example how palliative care is going now in developed countries. This is the example of the United Kingdom in 2009. This means 5 years ago. More than 200 hospice and palliative care inpatient units, more than 3,000 hospice and palliative care beds, more than 300 home care services, more than 100 hospice at home services, around 300 daycare centers, more than 300 hospice support services for children, 41 hospice inpatient units, etc. More than 100,000 people volunteer in local hospices. An army of volunteers just for the hospice service. And they spend daily 1.4 million UK pounds. Okay, I calculated in Egyptian pounds, it comes like 1 or 2 million Egyptian pounds, a billion Egyptian pounds a year. Okay? And around 2/3 of this amount of money spent comes from charities. The government pays only 1/3 of this amount. And this is the example for the States. These are the number of hospitals which have palliative care teams. I believe that no hospitals in the States can have accreditation without having palliative care teams. This is what I believe. I heard that before. Now there are states in the United States, all the hospitals in the States, they have palliative care team within the hospitals. Okay? When to start palliative care? The old model is patients continues disease-modifying treatment until the oncologist says there is nothing more we can do. At this point, they refer the patient to palliative care. And this is the wrong model because it does not allow the early identification and medical assessment of symptoms. Now, the WHO advocates this model. From the point of diagnosis of advanced cancer, the patient starts disease-modifying therapy with palliative care. And we have good evidence now that this model improves really the quality of life of patients. Start the palliative care as early as the diagnosis of incurable disease. And continues even after death by bereavement services for the bereaved families. What are the models of palliative care? Delivery, home. This is the gold standard palliative care actually, because most of the people prefer to die at home. So if you can deliver palliative care to patients at home and help them die peacefully at home, you are doing a noble job. Outpatient centers, outpatient clinics, tertiary palliative care units, and by tertiary palliative care units you mean units within hospitals. Day hospital, acute care hospital, inpatient hospice unit, separate building. So as the patient, if he has less distress and much support, he can go to home. If he has much distress and no support, he can go to inpatient hospice unit. If he has much distress, for example, emergencies that needs hospitalization, he can go to acute care hospital, and after being distressed, he can go home if he has good support, or go to a hospice if he has no support at home. Okay? I will stop at this point. I'm sorry because I ran through the slides, but I'll just give you an idea about what's palliative care and what's the definition. Again, palliative care is an approach of care that improves the quality of life, and it can be delivered by different models. And in each culture, in each country, with the different resources, everyone can start palliative care with whatever he can start with. Okay, and today we will have some examples. One successful example from Lebanon, where we Dr. Heba Osman, and another successful example, which I'm proud of, actually from Egypt, from Jussab Foundation, and I'll talk a little about our small service in Qasr El Ain after that. Okay, thank you. And
thank you, Professor Sami. The floor is open for questions. One or two questions. Rapid questions. Professor Sami, what do you think in Egypt, in our situation, palliative care, should we can start hospices in Egypt? Should we do palliative care units attached to the hospitals? What's the best in our situation?
actually, this is not an easy question. Okay, I'm sorry that I ran through my presentation, but in my presentation, I wanted to say that all models of palliative care, they have their own pros and cons in it. Okay, so as the patient, whenever the patient, whatever the needs of the patients, he can find a service. Okay, but to answer the question more clearly, it's better to allocate resources, especially if you have limited resources, to what suits you best. Okay, that's why it should be researched first. Okay, we should not rush into large programs or funding huge projects without going with evidence base. Okay, and for example, in a study that will show after a while, that 3/4 of our patients die at home. Okay, so if I have 10 pounds, I will spend 9 of these 10 pounds for patients to deliver palliative care for these patients at home. Okay, and we don't know what would be the response of our culture to standalone hospices. Do you have an experience in Lebanon about having a hospice? What's the opinion of people?
We don't have it.
Don't know. Yes, no. The opinion of people. Did you talk to anybody about this? Having a standalone hospice?
And our experience shows that in general people prefer to go to the hospital. So I'm surprised that you're saying in Egypt most people are dying at home, because it's part of showing the person you love and affection, and if you're caring for them when they're dying, you put them in an ambulance and you rush them to the hospital.
Yes,
so,
exactly.
most people tend to die in hospitals. I don't know how open they would be to come to the hospital.
Yes. And if I'm going to start myself, okay, I will start with a home care service, with a hospital-based service. Okay? But this is not the situation with the Jussab Foundation. For example, they want to have a standalone hospice. In the Gulf area, they have no experience about that. The culture there is much against having standalone hospice. They prefer hospital-based units rather than standalone hospices. Okay, but now in Kuwait they have a standalone palliative care center, but still they are facing the same problem. Okay, they are afraid that the people may say that this is the place of death. Okay, that's why they get the stigma of the death place. That's why it was a 92 beds building. They gave a complete 1 floor to the radiation therapy section. So patient can go there and go for radiation, admitted, discharged, not all the patients are dying there. Okay, so probably we will learn from our experience. We will know what will happen. We don't know yet. You are going through your projects, we are doing our project, and we'll see what will happen, inshallah. So there is no completely right or completely wrong. But it's better to allocate the resources to what suits you best. And in my opinion, we need strong home care services in our culture.
I think that the first step which must be stressed in Egypt is to increase awareness of the community, of the physicians, of the nurses about palliative care. This is the first step. If we do this properly, I think resources will be present because we are in community, kind people. I think we have to stress on awareness during this year at least to increase knowledge and methods of treatment of symptoms in cancer. Thank you.
I'm sure I agree with you 100%, and we are looking for cooperation, inshallah, to do that in the future, inshallah.
Any more questions?
Now, Professor Heba Othman from Lebanon, she will talk about palliative care delivery models, Lebanese experience.
Hello. Okay, so I'm going to be sharing this experience. I really appreciate the opportunity to do this. I think in all of our region, we're all starting from nothing, and learning from each other's experiences will help us not make the same mistakes. Culturally, I think we're very different from the places that we're learning from, so things will probably evolve very differently in our area. So what I'm going to do, I'm involved in 2 different projects in Lebanon, and we've moved forward a lot in the last few years. I'm going to share those 2 experiences and our experience on the national front. And what I've tried to do is reflect on the challenges and the opportunities and what worked and what didn't work, so that hopefully you can learn not to do what we did wrong and learn to do what we did right. I think most of you know Lebanon. You can't really see it on the map. It's a tiny country, 10,000 square kilometers, and our population is 4.5 million, which is about half the population of Cairo, I think. So we have a tiny country, and I think that has its benefits. I think the challenges of implementing palliative care in a country as huge as yours is much bigger. For us, making little changes helps, because word of mouth helps us a lot. You take care of one family and all of a sudden the whole city knows about what you've done. And so spreading the news about palliative care and increasing awareness is happening, I think, at a much faster rate than it would in a large country like this one. Our health system is mainly privatized, so people pay out of pocket. Our largest insurer is the National Social Security Fund, and the Ministry of Health is the insurer of last resort. So people who don't have private insurance and who don't have the means do get some coverage by the Ministry of Public Health. Mortality annually is about 23,000, and like Dr. Sani said, it's 10% are due to cancer. And here I try to do calculations of estimates of palliative care needs, and there are different ways to estimate. Some based just on cancer, and I know this is a cancer conference, but the wider definition of palliative care, we're trying to move away from restricting it to cancer, because people with other diagnoses can suffer, and people with other diagnoses can have a prolonged, protracted illness. So if you expand it to other diagnoses and you look at total mortality for patients with CHF and renal failure and neurodegenerative diseases, the palliative care needs in a country like Lebanon are somewhere between 14,000 and 18,000 patients per year. Again, I'm going to rush through some of my slides because I know we started late, and I'm not going to take the whole 45 minutes, but I'll start with, I just wanted to give you an idea of the evolution of things. People started talking palliative care in 1995 in Lebanon. At that point, only 95 patients in the whole country were getting morphine, and our morphine quota was 0.5 kilograms. And morphine utilization or consumption in a country gives you an idea of how well we're controlling people's pain. And it should be somewhere between 6 and 9. So you can see that 0.5 means that we had a lot of people with uncontrolled pain in the country. And at the beginning, there were a few conferences and symposia and some recommendations submitted to the Ministry of Health and the WHO about starting palliative care. And this took us early into 2000, where more patients were getting opioids. Our morphine quota went up a little bit, but still there weren't any palliative care services on the ground. 2004 was a landmark year for us in terms of legislation, because before that, we could only prescribe opiates to patients for 2 weeks at a time, and the patients themselves actually had to go, so a family member couldn't go and get their morphine for them. And then we were not allowed to stop treatment and put a do not resuscitate order in the chart for patients. So the new law said that if care was deemed futile, then we could stop aggressive therapies, and that was a huge change. In 2006, they expanded the morphine duration prescription for 1 month, so you could get 1 month's supply at a time. And another big change was an acknowledgement that people who don't have cancer could also have severe chronic debilitating pain. So they expanded prescriptions to non-cancer patients. Before, you actually needed to have a pathological diagnosis of cancer to be able to prescribe opiates to patients. In 2010 is when we started services. 2 NGOs actually started in 2010 providing community-based palliative care. And this wasn't really by choice. The reason we started in the community, I think it was because it required less resources. We didn't need a physical structure, we didn't need space. Patients were in their homes and we were going and providing care to them at home. Actually, at that point in 2009, I had tried to start at the American University of Beirut, but logistically getting the structure to start was really impossible. Going out into the community and starting it in the home was a lot easier, and the barriers were a lot less. What we did was we got donor funding at Bensum, and we started providing care in the community. And now in retrospect, I think it was a very good place to start, because now that we're working at the university hospital, building palliative care there, when we're trying to discharge patients home, which we know is the place of preference for people when they're sick, if we didn't have home or community-based palliative care services, we really wouldn't be able to discharge them. So having a good structure in the community, you can manage patients in the hospital and then know that they're going home and will be supported at home. In 2011, we established a National Committee for Pain Control and Palliative Care under the Ministry of Public Health. You can't really see in the slide, I have the decree in the slide. And this was a big step for us, because this was very much supported by the Ministry of Health. You can see in the slide the Director General of the Ministry of Health was the chair of the committee, and very, very supportive, as well as the Minister, of starting palliative care and looking at developing a strategy for palliative care for the country. And this committee has 4 subcommittees, one on research, one on practice, so setting guidelines for hospitals and physicians, one on policy, and one on education. And these subcommittees got working on developing a strategy for the country. And in 2012, on World Palliative Care Day, which is usually in October, we had a conference where each of these subcommittees presented their recommendations on what we need to do to move forward in palliative care in the country. In 2013, this year, we had a huge step, which was the recognition of palliative care as a specialty. We're very proud of that, because we feel that this step opens the door for many other things, starting educational programs, getting insurance companies to reimburse palliative care services. So recognizing palliative care as a medical specialty will open lots of doors for us. Also, at the American University of Beirut, we established the first palliative care service only in August 1st, we started, and I'll be sharing some of our data with you. And the Lebanese Medical Journal had a full issue dedicated to palliative care and the reports of those 4 subcommittees and the recommendations. And that just came out in November. So I'm going to share with you the experiences of Bensum and the American University of Beirut. The Bensum is the Lebanese Center for Palliative Care, and we aim to relieve suffering and improve quality of life of people with life-threatening or life-limiting illness through patient care, advocacy, capacity building, and research. So only part of what we do is patient care and delivering palliative care at home. A lot of our other efforts, as you can see, are related to changing policies and lobbying, and we played a major role in starting the National Committee and are working on changing laws to support the development of palliative care in the country. Our team, we started out very small. Actually, you can see this is how we started. We were just a couple of part-time nurses, myself, a pharmacist, and a psychologist. Now we have 2 physicians. One of them lives in the US but comes for about 5 or 6 months a year to help us out. She's a physician with 15 years experience in hospice and palliative care in the US. We have a clinical psychologist who's part-time, a clinical pharmacist who's also part-time and still a volunteer. We all started initially as volunteers and now we're paid staff. We have 3 nurses, 2 part-time and 1 full-time, a social worker who is part-time, and an outreach coordinator who does a lot of our work in terms of fundraising and social media and increasing awareness. Our services were available 24/7 to our patients. So for the past 4 years, I've been on call 24/7, and that's why I walk around with my telephone with me even when I'm in Cairo. And our services are free of charge. And we were very committed to doing that because we didn't want these services accessible to only people who could pay for it. So the people who have money usually donate money, but the people who don't have to worry about paying for the service. This is just to show you our referral rate. So when we started, we would have 1 or 2 patients at a time, and we wanted it this way because we were building. We were building the NGO where we're developing policies. We were playing with what worked and what didn't work. Now we have an average census of 11 or 12 patients at one time. I'm not going to go to the details. We have something called partial support and full support. Partial support are usually people outside of Beirut who are too far for us to reach. We might visit them once or support them over the telephone. Full support are patients that we take on and visit 24/7 whenever they need it. But you can see the numbers. We had 55 people admitted to care in 2012. We had 90 people admitted to care in 2013. The not admitted were people who really did not meet the needs of the requirement for palliative care services. As you can imagine, most of our cases are cancer cases, but not all of them. In 2012, 47 of our total 55 patients were cancer patients, and only 8 were non-cancer. But you can see in 2013, that number has changed, so only 70% are cancer patients. We deal with lots of other diagnoses, including heart failure and neurodegenerative illnesses like ALS and multiple sclerosis, advanced Alzheimer's. And this is the number of days in care. So you can see that the need is, once the service is there, utilization does definitely increase. One of the things when we first started, referral by physicians was low, and I'll talk about this in our challenges. So most people were self-referred or referred through our website. And the referrals by physicians increased over time. So only 13 patients were referred by a physician in 2011 when we started, 41 in 2012, and 52 in 2013. The total number of referrals went up, so the proportion of referrals by physicians doesn't really increase, it actually decreases. But I'll talk a little bit about the numbers that when they do peak when we go on TV or when we do any kind of awareness raising efforts. But physicians are recognizing the value of the service, and especially oncologists are referring much more frequently. So these are our advocacy efforts. In 2011, we just had a couple of appearances on a story on Al Jazeera and Melody FM as a radio station. This is 2012. And this is 2013. So we're getting much better at raising awareness, and we're putting more efforts into it. And these things kind of snowballed. So in 2013, I think one of the reasons we did this is when we got palliative care was recognized as a specialty, we did a press release and we sent it to the newspapers. It was covered in the newspapers, and people got interested and they wanted to cover it in television. And Nashra is an online news source, and we agreed with them. They have a health column, and we agreed with them to have regular columns to talk about different palliative care issues. And so some of them are related to what the social worker does, some of them are related to what the pharmacist does, so we have a list of topics that they do regularly. I was going to show you one of our clips. I don't think we have the time, so I'm going to skip this. I'm just going to say we have on our website, and I'll give you the resources, all the clips of things that came out on TV. The one I picked was a 2-minute clip. I picked it because it was short, but I also picked it because I thought it was important to tell you what kind of message we're trying to relay. And in palliative care, there's often this loss of hope. People are dying, there's no hope, there's nothing we can do for them anymore, so they need palliative care. And we're trying to change this message. So as part of our awareness raising, what we say is palliative care is not about dying, it's about living. And the woman who's profiled in the story is a woman with advanced ovarian CA who came when we started taking care of her. She had horrible ascites, she was getting some palliative chemotherapy, and she's doing fine. And she's doing so well that in the last year she sat down and she wrote a cookbook, and she published a cookbook. So getting palliative care and getting support has made her strong enough and functional enough that actually she was productive despite her illness and despite her treatments. Our interest is definitely growing, so like I said, we're working on social media to raise awareness. And these are our Facebook likes, so they've increased 120% between 2012 and 2013. We have followers on Twitter. The hits on our website went from 7,000 to 11,000. So having an outreach coordinator has helped us a lot with that. These are the countries from the Arab world that have accessed our website, and I just thought I would share those. So we've noticed that interest is growing significantly. So when we discuss reflecting on the challenges since we started and what worked and what didn't work, we divided them into the healthcare provider level and families or caregivers. And at the healthcare provider level, we initially felt that we had a lot of resistance because doctors were worried we were going to take away their patients. And when their biggest source of income is providing more chemotherapy, they worry that we were going to talk them out of getting chemotherapy, or they were going to get less admissions, therefore less income. They were worried about losing income, and they weren't convinced that we could do something that they couldn't do. So a lot of the physicians felt that they could provide palliative care and they didn't need this additional assistance. And the physicians themselves really had a very limited knowledge, and they still do, of what palliative care is. Patients are asking for palliative care, and they say, no, they're not at the palliative care stage yet. They wait until the very end when they refer them to palliative care. What worked for us really well with healthcare providers we worked with is regular communication with them. So now when we have our weekly team meetings and we discuss our patients, we have little summaries for each patient and we email them to the physicians so they're kept in the loop. And this has worked brilliantly for us, and I strongly suggest we do that. So the palliative care team and the treating primary physician are in touch, and the treating physician doesn't feel like he's being pushed out of the picture. If we make any major decisions, if the patient makes any major choices, we pick the phone up and we call them. So for the routine stuff, they get an email, but any major changes, they get a phone call. Restricting our service to the home so that when patients get admitted, we're not taking care of them, has helped with this territorial issue, so doctors don't feel that we're taking away our patients. And as we provide care, they've noticed that we do things differently. So when we have, one example I like is patients with a small bowel obstruction, and this is something that we see frequently in pancreatic cancers and ovarian cancers, and when it's inoperable, they put the NG tubes and the patient has intractable vomiting, and we have simple medications that can fix this. And when these physicians see that we can fix this with medications and the NG tube is out and patients can actually eat, this starts to convince them that our approaches in palliative care do make a big difference. Two of our part-time nurses are affiliated with the hospital as well as Benson, and this has helped us a lot because we have communication between the two through them, and that's worked really well for us. As far as families, one of the big challenges was they equated asking for palliative care as giving up. So you ask for palliative care when you lose hope. And this is a huge step. A lot of people keep saying, no, we're not ready yet, we're not ready yet. And then when they ask for palliative care, they really see the difference it's made for them, and they appreciate the difference. And most of the time we hear, we wish we had asked for this earlier. But taking that step to ask for Balsam to come and help them at home is psychologically very difficult for them. They really don't know what the team can offer, and they worry about losing this relationship, this established relationship with their treating physician, whether it's an oncologist or whatever their specialty. And this is something that worries them. One way that's helped us is we provide equipment. What worked for us a lot at Balsam is when patients die, they usually turn around and donate their equipment. So we've bought 1 hospital bed, but now we have 6. Air mattresses, wheelchairs, walkers, things like that. So we have those, and patients see when they get our service, they get those for free, and that has made it easier. So they think, okay, they're talking to us because they're going to get the equipment, but then once we're in the door and we're helping them, they see the bigger benefit, and we build trust. And we always reassure them that their physician is going to stay involved in their care, and that's helped a lot. As far as AUB, our experience obviously is much more limited. We started August 1st, so we have only 4 months of experience. AUB MC has a Vision 2020, and it is to become a leading academic medical center in Lebanon and the region, delivering excellence in patient care, outstanding education, and innovative research. And part of that is they want a center of excellence, a cancer center, a regional cancer center, which requires a good palliative care program. So as part of that vision, they were interested in incorporating palliative care, which we're very happy about. And the exposure is huge because they graduate now about 100 medical students per year. This is, I don't think, very big by Egyptian standards, because I'm sure your classes are much bigger. But we're exposed to 100 medical graduating students per year, 82 residents per year. The hospital beds, there are about 400, but the projection is we're going to have 600 hospital beds, and that's the biggest teaching hospital in Lebanon. So we established the first palliative care service there, and the service includes 3 physicians, of course part-time, we all have different jobs. I work at Balsam and I'm a family doctor. There's a geriatrician, there's another family doctor. We have a psychiatrist who's part of the team, a clinical pharmacist who happens to be the same clinical pharmacist at Balsam, 3 part-time nurses, and a social worker. And these are the numbers of consults since we started. We've only had 33 consults, but you can see in the beginning it's very low, and the numbers are slowly increasing as people start to remember we're there. And these peaks are associated with my presence on the floor. So I know when people see me, they remember, but when we're not around, they forget that there's such a service. And one thing we're talking about is maybe attending rounds with the medical team so that they remember to consult us. But clearly there's an interest, and the nurses and the residents and the students often will sit down with us when we come to see a consult to learn what we do and learn to do it themselves. As far as diagnoses, you can see the large proportion is cancer, but we have non-cancer diagnoses here as well. And the referring services are primarily oncology, but other services, especially the critical care units, are starting to consult us. Most of the consultations are for symptom management, but some are for discharge planning to help them get patients home, goal setting to discuss about code status, pain management, and psychosocial support. So the plan now, we started with a consultation service because, again, it doesn't need a space, it doesn't need, so allocating resources becomes easier, but the plan is to start an inpatient unit, outpatient clinics, and on the educational front, we're starting to integrate palliative care into the undergraduate medical curriculum, soon into residency programs, and hopefully have a fellowship program, and we're starting a research program as well. No challenges or opportunities or what worked and what didn't work at AUB, because I think it's too early on. Hopefully the next time we talk, I'll have more to share with you about what worked and didn't work with us at AUB. On the Lebanon front, on the national front, I wanted to share some issues as well. I'm not going to talk about opioids because I think just in the interest of time, just notice that in terms of morphine equivalence and consumption of opioids, you can see that it's increasing over time, so we're getting better at managing pain. This is Lebanon is this one, and I think Egypt is this one. And this is the regional mean, but the global mean is around 6. So the global mean is off this chart. So we're not doing very well regionally in terms of opioid consumption. On the national front, what has been challenging for us is palliative care services are not reimbursable. Legally, advanced care planning, which is a concept that works very well in the West, I can say in the West now, if I get really sick, or if I get hit by a car, or if I get advanced cancer, I don't want artificial feeding, I want this, I don't want that. Legally in Lebanon, people cannot do that. And that doesn't help. So when somebody has a really advanced illness and there's futility of care, getting decisions made becomes more difficult. We have huge restrictions in terms of accessibility to pain medication, and not enough people who are trained in palliative care. But our big opportunity is we have great support from the Ministry of Public Health. And I'll tell you again here, the fact that we're a small country helps us very much, because I mentioned the Director General of the Ministry of Public Health. He had a brother who was very sick with hepatocellular carcinoma, and we helped his brother, and this really opened his eyes to what the service can do. So in countries that are small like that, you have people in key positions, and they see the benefit of the service, and they become your strongest advocates. We have the National Committee, and again, the size of the country helps us a lot. So now that palliative care is recognized, hopefully we'll get insurance coverage, educational programs, more hospitals will start building palliative care services. We want to start working on laws and policies to move things forward, and help hopefully develop a good, solid national strategy to move palliative care forward. I think that's it. And my contacts are here if anybody is interested in communicating with us.